Welcome to Vitals and Veins, where we break down the real work behind patient care, built for medical assistants, phlebotomists, and EKG technicians. From students working toward certification to seasoned pros keeping their credentials current, this podcast is for those committed to doing the job well at every stage of their career. Let's get into it. Two healthcare workers experience a Sharps injury on the same day. Same hospital, same shift, maybe even the same unit. One accidentally brushes against a clean lancet while cleaning up a workspace. It leaves a tiny, superficial scratch. The other sustains a deep needle stick from a hollow bore needle immediately after a blood draw on a patient whose infectious status is unknown. From a clinical standpoint, these are very different situations. Different devices, different levels of exposure, different levels of transmission risk. But emotionally, they may not feel different at all, because the human brain doesn't always respond to clinical probability. It responds to uncertainty, to fear, to the sudden realization that something crossed a line that wasn't supposed to be crossed. And if you've worked in healthcare long enough, you probably know the exact moment I'm talking about. That split second where your stomach drops before you've even fully processed what happened. You replay the movement immediately. Wait, did that actually puncture the skin? Was there blood? What device was it? Was it used? What happens now? And within seconds, your mind can go from routine workflow to worst case scenario, even before you have actual information. That reaction is incredibly common, and honestly, it makes sense. Because Sharps injuries occupy this strange space in healthcare where the clinical realities and the emotional experience do not always match. Some low risk exposures can create enormous anxiety. Some higher risk exposures get minimized or brushed off. So, today, what I'm unpacking, not all exposures are the same. Not clinically, not procedurally, and not psychologically. Understanding those differences matter more than people realize. So, I'm your host, Nichelle, and if you've been following this Sharps Exposure series, we've looked at this issue from a few different angles already. In the first episode, I shared my own exposure experience, what happened, how it unfolded, and what that process felt like from the inside. In the second episode, we focused on what a strong post exposure response system should actually look like, not just on paper, but in real practice. And in our most recent episode, we talked more about the emotional side of exposures, the anxiety, the waiting period, the uncertainty, and the impact workplace culture can have on how supported someone feels afterward. But today, I want to shift gears a little because one of the biggest problems in healthcare exposure education is that many people are never really taught how to distinguish one exposure from another. Everything gets emotionally grouped under needle stick. And clinically, that's just not accurate. Risk assessment is actually much more layered than that. The type of device matters. The type of injury matters. Whether blood was involved matters. The source patient matters. The timing matters. All of these pieces contribute to the overall picture. And when you understand those layers, something important happens. You stop viewing every exposure through the exact same lens. Now, to be clear, that does not mean minimizing exposures. Every Sharps injury deserves proper reporting, documentation, and evaluation. But understanding relative risk helps reduce the confusion, improves the response, and honestly, can reduce a tremendous amount of unnecessary fear, especially for newer healthcare workers. Because one thing I've noticed over the years is that people are often taught exposure protocol without really being taught exposure interpretation. And those are two different things. So, in this episode, we're going to walk through some of the major factors that influence exposure risk, some common misconceptions, and the difference between perceived danger and actual clinical assessment, not to create false reassurance and not to encourage people to dismiss injuries, but to create clarity, because clarity changes how people respond in the moment. Before we get into today's discussion, I want to quickly thank the educational platform supporting this podcast. Reading rhythms is your craft. Keeping your certification current shouldn't be the hard part. EKG delivers focused, continuing education built for EKG technicians on your time, at your pace. Knock out your CE hours at ekgce.com. All right, so let's start with something that I think sits at the center of almost every sharps exposure experience: the difference between perceived risk and actual clinical risk. Because those two things are not always aligned. And honestly, in the moment, they usually aren't. When a sharps injury happens, your brain does not pause and calmly run through a structured risk assessment algorithm. It reacts emotionally first. There's usually a very immediate physiological response, that rush of adrenaline. Your stomach drops, your chest tightens. You replay the movement in your head almost instantly. And then the questions start. Did it break the skin? Was there blood? Was the device used? What patient was that from? What if they have something? What do I do now? Am I overreacting? Am I underreacting? And what's important to understand is that this reaction happens before most people have enough information to accurately determine risk. So the emotional response often fills in the gaps. And humans are very good at filling uncertainty with worst case scenarios, especially in healthcare, because we're trained to think about consequences. We're trained to anticipate danger. We're trained to consider what could go wrong. That mindset is useful clinically, but psychologically, after an exposure, it can spiral very quickly. And one of the reasons that happens is because many healthcare workers have a very broad understanding of bloodborne pathogen risk, without necessarily understanding how exposure risk is stratified. So the brain hears needle stick and immediately jumps to HIV, hepatitis, life changing exposure, even when the actual situation may be much lower risk clinically. And that disconnect matters, because emotional intensity is not a reliable indicator of transmission probability. I want to say that again because I think it's incredibly important. Emotional intensity does not necessarily reflect clinical severity. A low risk exposure can feel terrifying, and sometimes higher risk situations are initially brushed off because the person is distracted, overwhelmed, embarrassed, or trying to keep working. Healthcare workers are humans first, and humans are not perfectly rational under stress, and that's normal. But it's also why education matters so much here. Because understanding how risk is actually evaluated creates structure during a moment that otherwise feels chaotic. And structure changes how people experience uncertainty. Now, one thing I want to be careful about in this episode is this: understanding relative risk is not the same thing as minimizing exposures. Every sharp injury should still be taken seriously. Every exposure should still follow protocol. Every incident still deserves proper documentation and evaluation. This isn't about saying don't worry about it. It's about avoiding two extremes that happen all the time. One, treating every exposure as catastrophic regardless of circumstances. Or two, dismissing exposures because they seem minor. Neither response is ideal. And I think this becomes especially important for newer healthcare workers. Because if your only understanding of Sharp's injury comes from generalized safety training, everything can start to blur together emotionally. You hear statistics, you hear about bloodborne pathogens, you hear about occupational exposure, but sometimes nobody really explains what actually makes one exposure higher risk than another. So all exposures start to feel equally dangerous. And when that happens, anxiety fills the space where education should have been. Think about a lot of mandatory annual safety education. The emphasis is often be careful, protect yourself, report exposures, use standard precautions. All important things, but many trainings spend less time teaching people how risk assessment actually works in real practice. So, when an exposure happens, the healthcare worker may know the steps without understanding the context. And I think context matters because a superficial scratch from a clean device is not evaluated the same way as a deep injury from a contaminated hollow bore needle. A needle stick involving visible blood is different from incidental contact with an unused device. These distinctions are clinically meaningful, and once you understand that, exposure stops existing as one giant, undefined category in your mind. They become accessible, layered, structured, interpretable. And that structure is important psychologically too, because uncertainty tends to amplify fear. When people don't know how risk is determined, they often assume the worst simply because they lack a framework for interpreting what happened. And honestly, sometimes healthcare culture unintentionally reinforces this. You'll hear coworkers say things like, "Oh my God, I would panic. That's terrifying. I'd lose my mind. What if you caught something?" Again, human reactions, very understandable. But those reactions can increase emotional distress before actual risk assessment has even occurred. And this is why calm, informed response systems matter so much. Because right response does two things simultaneously: it protects clinical safety and it reduces unnecessary panic. And those are not opposing goals. You can take exposure seriously without escalating fear unnecessarily. In fact, that's probably the ideal approach: a structured response, a measured response, a clinically grounded response, but not dismissive, not catastrophic, just informed. And one thing I think healthcare workers deserve more education on is this: risk assessment is not guesswork. There are actual factors that trained professionals use to evaluate exposure severity. Those are type of device, presence of blood, depth of injury, nature of exposure, source patient information, timing, post exposure actions. These are all pieces of a larger clinical picture, which means the goal after an exposure is not panic until proven safe. The goal is gather information, follow protocol, and evaluate appropriately. That doesn't eliminate anxiety completely, of course not, but it replaces some of the uncertainty with process. And psychologically, that makes a huge difference because fear tends to grow in environments where there's no structure. And honestly, I think that's one of the biggest themes of this entire series. Not just sharp safety and not just exposure protocols, but reducing the gap between what healthcare workers feel and what they actually understand. Because when those two things are completely disconnected, fear tends to take over. And when people have clarity, they make better decisions, they communicate more effectively, and they navigate these situations with a little less chaos internally. So, now that we've talked about perceived risk versus actual risk, let's move on to one of the biggest factors that influence exposure severity in the first place: the type of device involved. Honestly, I don't think this gets emphasized enough in a lot of workplace trainings because when people hear the phrase needle stick, they often picture all sharps injuries as basically interchangeable. But clinically, they're not. The device itself changes the level of concern significantly in many situations. And this is where exposure assessment starts becoming much more specific. So let's walk through a few examples. Imagine a healthcare worker sustains a deep puncture from a hollow bore needle immediately after drawing blood from a patient. That's one scenario. Now compare that to a superficial scratch from a clean lancet that was never used on a patient. Those situations are not clinically equivalent, not even close. But emotionally, the initial reaction may feel very similar. Device type matters for a reason. A hollow bore needle is considered higher risk largely because of its structure. The inside of the needle, the lumen, can retain blood. And if that blood contains a bloodborne pathogen, there is a pathway for transmission. That's why hollow bore needles are often discussed so heavily in occupational exposure literature, especially needles used for venipuncture, IV access, blood collection, or injections. Now, compare that to something like a solid needle, like a suture needle, for example, does not have that same hollow channel holding blood internally. That does not mean there is zero risk, but the mechanics of the exposure are different. And this is an important distinction. Risk assessment is often based on transmission potential, not just whether skin contact occurred. That's a very different framework than how most people emotionally process the event. Because emotionally, the brain often simplifies it to a sharp object just punctured my skin. But clinically, exposure evaluation becomes much more detailed than that. What type of device? Was it visibly contaminated? Was it used? What procedure was it used in? Was blood present? Did it penetrate gloves? How deep was the injury? I mean, all of those details matter. And once you start looking at exposures this way, you realize why occupational health departments ask so many questions afterward. They're not just being repetitive, they're building a risk profile. Now, something else that contributes to confusion is that healthcare workers use a huge range of sharp devices every day, right? We have needles, butterflies, syringes, scalpels, lancets, capillary collection devices, suture needles, IV stylets, broken ampules, glass slides, even exposed, contaminated equipment edges in some cases. But from a transmission standpoint, they are very different categories. Again, another example, a clean scalpel injury in a sterile field is evaluated differently than a blood filled, hollow bored venipuncture needle. A superficial scratch from an unopened equipment is different than a contaminated device that was actively used in a procedure. And again, that does not mean minor exposures should be ignored. Healthcare workers are actually very bad sometimes at self determining what counts. People minimize things constantly. Oh, it barely poked me. Ah, it didn't bleed. I'm probably fine. Not a big deal. And unfortunately, that mindset can lead to underreporting, which creates problems later, of course, because healthcare workers should not be independently deciding this exposure matters and this one doesn't. The system should evaluate that, not individual panic and not individual dismissal. So now you have another problem. Device type may indicate meaningful exposure risk, but the injured worker delays reporting because emotionally, they're trying to minimize that situation. And this is one reason exposure education has to include both clinical education and psychological realism. Because people do not respond to exposures like robots. They respond like stressed humans working in demanding environments. And sometimes people swing in the opposite direction too. Sometimes a very low risk exposure creates overwhelming anxiety simply because the person does not understand the relative risk differences between devices. Healthcare workers are often taught broad danger concepts without enough practical risk interpretation. There's a difference between yes, blood-borne pathogens exist and exposures matter, and every sharps injury carries the same probability of transmission. Those are not the same statement. Now, another thing worth discussing here is visibility. Healthcare workers often judge exposures based on what they can physically see. Visible blood tends to trigger more alarm, and understandably so. But absence of visible blood does not automatically mean absence of risk. At the same time, visible blood does not automatically mean catastrophic risk. Again, it's layered, but real exposure assessment usually exists in a gray area initially. Information has to be gathered. Context matters. Source information matters. Device information matters. That's why education around device type is so important, because when healthcare workers understand why certain devices carry higher concern, the whole assessment process starts to make more sense. It stops feeling random. And honestly, this also improves communication after an exposure, because instead of saying, I got stuck by a needle, people start understanding how to communicate more useful information. What kind of needle? Used or unused? Hollow bore or solid? Visible blood? Depth? Procedure involved? Those details matter enormously to occupational health teams because they change the overall clinical picture significantly. And one thing I think is reassuring for healthcare workers is to remember this. Post exposure evaluation is not based on panic, it's based on evidence, transmission patterns, documented risk factors, and structured assessment. That does not make exposures emotionally easy. Of course not. Uncertainty feels much worse when you don't understand the process. So, another major factor in exposure assessment is the depth and nature of the injury. And again, this is one of those areas where two injuries can look somewhat similar at first glance, while carrying very different levels of concern clinically. Because not all skin contact is equal, not all punctures are equal, and not all exposures create the same opportunity for transmission. So let's compare a couple scenarios. Imagine one healthcare worker experiencing a very light graze from a sharp edge. Maybe it barely breaks the skin. Maybe they aren't even sure at first whether penetration occurred. Now, compare that to a deep puncture injury involving significant force and visible bleeding, and a device that penetrated well beneath the skin surface. Those are very different exposure mechanics. And depth matters because deeper injury creates more direct access to tissue and blood vessels. In simple terms, the more significant the penetration, the greater the opportunity for infectious material to enter the body if contamination is present. Now, I do want to be careful here because depth alone doesn't determine the overall risk, but it's important. You cannot isolate one variable and make conclusions from it independently. A deeper injury with a low risk device may still ultimately present lower concern than a superficial injury involving a high risk contaminated hollow bore needle. So, again, dealing with a layered assessment, not one factor decision making. So, now let's talk about another important nuance. Sometimes injuries that appear visually dramatic are not necessarily the highest risk exposures, and the opposite can also be true. Tiny puncture from a contaminated hollow bore needle may actually carry more concern than a large looking superficial injury from a clean instrument. That surprises some people because visually humans tend to judge severity based on appearance. We associate bleeding, pain, visible injury all with greater danger. But transmission risk depends more on exposure mechanics than appearance. Now, another thing that complicates injury assessment is that many exposures happen incredibly fast. There's often incomplete memory of exact mechanics. People say, I'm not sure how deep it went. I think it punctured. I don't know if it actually broke the skin. I saw a mark, but I don't know if it bled. That uncertainty is extremely common because these incidents usually happen during active workflow. Patient moving unexpectedly, disposal interruption, sharps container overfilled, fast paced environments, fatigue, multitasking, you name it. And afterwards, the healthcare worker is trying to reconstruct an event that lasted maybe half a second. And that's difficult, which is another reason why structured reporting matters so much, because people should not have to independently determine this definitely matters or this definitely doesn't. The evaluation process exists specifically because exposures often are emotionally and situationally complicated. Now, let's also briefly talk about glove use because this is another area people often misunderstand. Gloves are important, very important, but gloves are not magical barriers against sharps injuries. If a sharp penetrates the glove and the skin, exposure evaluation is still necessary. At the same time, gloves may reduce blood volume transfer in some situations, which can matter. So, again, layered assessment, not simplistic yes or no thinking. So, we've talked about device type and we've talked about the depth and nature of injury. Now, let's talk about what is often the biggest source of anxiety after a sharps exposure, the source patient. Because once an exposure happens, this is usually where people's minds go immediately. What do we know about the patient? Have they been tested? What if their status is unknown? One of the most important things to understand is this: unknown status does not automatically mean high risk, it means unknown. That distinction matters. And sometimes people begin doing that almost immediately. They looked healthy, they looked sick, they had tattoos, they were elderly, they were young. Healthcare workers intellectually know bloodborne pathogens are not visually identifiable, but stress pushes humans toward pattern seeking and assumption making. That's one reason occupational exposure systems rely on structured assessment rather than instinct or appearance. Now, of course, source patient information does matter. If a patient is known positive for a bloodborne infection, that changes the assessment process. If a patient is known negative, then that can substantially reduce concern. And if the status is unknown, occupational health evaluates the exposure using the device involved, the type of injury, available clinical information, institutional protocols, and follow up testing procedures. Again, structured assessment, not panic based interpretation. Maybe testing is delayed. Maybe consent issues arise. Maybe the patient already left, and maybe the source is completely unidentified. Now, on the other hand, clear communication after an exposure can dramatically reduce distress. Quick testing, clear explanations, consistent occupational health follow up, defined steps. Those things matter psychologically just as much as they matter clinically. Clinically, labs, documentation, risk assessment, follow up. Emotionally, fear, uncertainty, rumination, hypervigilance. And ideally, good exposure systems support both. Because technically correct protocols can still feel deeply distressing if communication is poor or the workplace response feels disorganized. So, now that we've talked about how source patient factors influence exposure assessment, let's move into another piece that's often underestimated entirely: timing. What happens in the first few minutes after a sharps injury matters more than many healthcare workers realize. Because once the exposure has occurred, you can't undo it, but you can influence how quickly the situation is assessed, how efficiently follow up begins, and how clearly the event is documented afterwards. And because of that, many healthcare workers instinctively try to keep working immediately afterward. I'll deal with this in a minute, or let's finish this first, it's probably fine. That response is extremely common, but delays can complicate the process quickly. Immediate cleansing following institutional protocol is important, of course, but what often matters just as much as everything that comes after that: prompt reporting, occupational health notification, documentation, source patient coordination, and timely evaluation if additional interventions are needed. But exposure systems only work well when reporting is normalized, because once people begin informally deciding this probably isn't important enough, underreporting starts becoming part of the culture. And that creates problems later down the road. And now they're managing both the exposure itself and growing uncertainty about whether they handled it appropriately. Now, another reason timing matters is that certain post exposure interventions are time sensitive. Not every exposure requires additional treatment or prophylaxis, but those decisions should come from structured evaluation, not delay or self reassurance during a stressful moment. That's exactly why structured systems exist. Now, another thing that deserves attention here is documentation, because details become harder to reconstruct later, like what device was involved, was the device used, was blood visible, how deep was the injury, what immediate actions were taken. Those details actually matter clinically, and delayed reporting often means fragmented information. Those experiences shape future reporting behavior too, because safety culture becomes visible in real moments, not just in annual training modules. And honestly, one of the clearest signs of strong healthcare safety culture is how organizations respond when something goes wrong. Not with panic, not with blame, just with structure, clarity, and consistency. So, we've talked about device type, injury depth, source patient factors, and timing. So, when you step back and look at everything we've talked about so far, one thing becomes very clear: risk is layered. It's not determined by one factor alone, not the device by itself, not the injury depth by itself, not the source patient alone, and not timing alone. It's the combination of factors that creates the overall clinical picture. But occupational exposure assessment rarely works in clear binary categories. Instead, it works more like pattern recognition. So let's compare two extremes: a superficial scratch from a clean, unused lancet versus the deep puncture from a blood filled hollow bore needle used during venipuncture on a patient with a known bloodborne infection. Most people immediately recognize those as very different situations. But many real world exposures fall somewhere in between. Maybe the source patient status is unknown. Maybe the injury was shallow. Maybe the device carried higher concern, but there was minimal visible blood. Maybe reporting was delayed. Maybe details are incomplete. That's why occupational health teams ask so many detailed questions after an exposure. They're building a layered assessment. They want to know what kind of device was involved, what procedure was involved, was blood present, how deep can you gauge the injury to be, what source information is available, and what immediate actions occurred afterward. Each factor adds context to the overall picture. They don't usually rely on one isolated finding, they evaluate patterns and context together. Exposure assessment works the same way. The goal is neither panic nor dismissal, the goal is information evaluation. Now, another thing I think healthcare workers sometimes struggle with is the fact that exposure assessment evolves over time. Immediately after an exposure, information is often incomplete, and then gradually, source information may become available. Testing results return, documentation gets clarified, follow up occurs, and the overall picture becomes more refined. Now, something else worth remembering is that recommendations after exposures are based on structured protocols, not emotional reactions. Different exposures lead to different recommendations because the layered risk profile differs. Sometimes follow up is minimal, sometimes additional testing is recommended, sometimes prophylaxis discussions occur. Those decisions are based on exposure factors collectively, not simply on how frightening the situation feels in the moment, and that's why structured protocols exist. But even when risk assessment itself is structured, human perception often isn't. So, next, I want to talk about why exposures that feel the most frightening are not always the ones carrying the highest clinical concern. So, after everything we've talked about so far, you might think, well, once people understand how exposure risk is assessed, this probably becomes easier emotionally. And sometimes it does, but human perception does not always follow clinical logic. Even when an exposure is ultimately assessed as low risk clinically, it can still feel overwhelming in the moment, because emotional intensity is not always an accurate reflection of transmission probability. A low risk exposure can still create intense fear, And in healthcare environments, perception is often shaped by uncertainty, previous experiences, and the stories people remember most. Healthcare culture tends to remember the dramatic exposure stories, the unusual cases, the incidents coworkers talk about for years afterward. Those stories leave an emotional impression, even when they are statistically uncommon. At the same time, repeated exposure to sharps incidents in healthcare settings can sometimes create overnormalization, too. People start thinking, this stuff just happens. Oh, I've seen worse. It's probably nothing. So, healthcare workers can end up pulled between two extremes: catastrophizing or minimization. Neither leads to ideal decision making. And that's why one of the most important things healthcare workers can remember is this: fear itself is not evidence of danger, and lack of fear is not evidence of safety either. Exposure assessment should be based on actual exposure factors, not solely on emotional instinct. And that's why structured protocols matter. So, now that we've talked about how perception can distort the way exposures feel emotionally, let's move into something more practical. Because there is still a lot of misconceptions surrounding sharps injuries that continue circulating in healthcare environments. I want to do a quick rapid fire breakdown of some of the most common misconceptions surrounding sharps injuries. Because honestly, there are a lot of half true ideas floating around healthcare environments, and some of them increase unnecessary fear, while others lead people to underestimate situations that absolutely deserve evaluation. So let's go through a few of the big ones. First, all needle sticks are high risk. Not accurate. Not all sharps exposures carry the same transmission risk. Device type matters, depth matters, visible contamination matters, source patient factors matter. That doesn't mean lower risk exposure should be ignored. It means exposures are assessed comparatively, not generically. Next, if there's no visible blood, there's no risk. Also, not accurate. Visible blood can absolutely influence concern levels, but absence of visible blood does not automatically eliminate risk. At the same time, visible blood also does not automatically mean catastrophic risk. Structured assessment matters more than visual reaction. Next is unknown patient status means worst case scenario. Emotionally, people often treat uncertainty like danger, but clinically, unknown does not automatically mean high risk. It means information is incomplete. That distinction matters enormously. Risk assessment should be based on actual exposure factors and structured protocols, not imagined worst case outcomes. Next, if it didn't hurt, it probably isn't serious. Pain is not a reliable indicator of exposure severity. Some injuries that barely hurt still deserve full evaluation, and some painful injuries may ultimately represent relatively low transmission concern. Ultimately, pain is not a reliable measure of transmission risk. Next, I was wearing gloves, so I'm fine. So, gloves are extremely important, but they are not absolute barriers against sharps injuries. If a contaminated sharp penetrates both the glove and the skin, evaluation is still necessary. Gloves reduce your risk, but they do not eliminate the need for assessment. If the patient looks healthy, the risk is low. This is one of the reasons standard precautions exist in the first place. Bloodborne pathogens are not visually identifiable, and occupational exposure assessment is not based on appearance. Visual assumptions are not reliable risk assessment tools. If it was a small injury, it's not worth reporting. This mindset contributes heavily to underreporting in healthcare. People tell themselves, it barely broke the skin, it's probably nothing, but exposure reporting should be based on protocol, not on instinct alone. That's why reporting systems exist. Experienced healthcare workers don't get nervous about exposures. Completely false. Experience does not eliminate emotional reactions to exposures. Understanding risk assessment may improve perspective, but uncertainty can still feel stressful. If occupational health seems calm, I shouldn't feel anxious. A calm, structured response is a good thing. That's part of effective system design. But emotional processing and clinical assessment are not identical. Someone can intellectually understand that an exposure is low risk while still feeling emotionally distressed by it. And honestly, I think one of the healthiest shifts healthcare workers can make is moving away from, does this feel serious? And toward, what are the actual exposure factors involved here? Because once you stop relying purely on emotional instinct, the situation becomes much more accessible. Not emotionally easy, mind you, but accessible. And really, that's one of the core messages underneath this entire episode. Sharp's exposure assessment is meant to be structured, not fear based, not guess based, and not determined purely by how emotionally intense the situation feels in the moment. Not all exposures carry the same level of risk, and understanding that distinction matters. Because when every exposure gets mentally grouped together in the same category, people either become overwhelmed by fear or they start minimizing situations that still deserve proper evaluation. Neither response improves safety. What improves safety is understanding. Understanding the device involved, the nature of the injury, source patient factors, timing, and the overall exposure context. That's what occupational exposure assessment is built around. Not to make exposures feel trivial and not to encourage people to dismiss injuries, but to replace uncertainty with understanding. Because understanding changes how people respond. It improves communication, reporting, decision making, and it makes these situations feel less chaotic when they do happen. Not easier, but more manageable. Thank you for spending this time with me today. And if this episode helped clarify something you've struggled with personally, or something that you think another healthcare worker needs to hear, consider sharing the podcast with that coworker, student, or healthcare team. I'm Nichelle, and this has been Vitals and Veins.